All right, and good morning in case you're just joining us. But if you're with us since we started the show till now, we have shifted gears into the health segment for this Wednesday. And we want to talk about combating tuberculosis, a conversation that is coming just a few days after our country joined the rest of the world to mark World TB Day. And the theme for this particular year is really, really encouraging. Yes, we can. And that is why we are having this conversation to talk about exactly how we can, and that means you and I and the whole nation can eradicate TB in our country. 10.6 million people fell ill with TB in 2022. That's according to the World Health Organization. 1.6 million people died. And of course, we are looking at some unfortunate, data that is telling us that our country is still ranking high among the 30 high-burden countries. And I'll be looking at some more numbers that actually bring this closer home to look at how Kenya is doing with my panel. This particular morning, it's a panel of two ladies who have a wealth of knowledge on matters TB. And of course, I'm hosting this morning Evelyn Kibuchi on my far left. She is the Chief National Coordinator, Stop TB Partnership Kenya. She's also a board member of the International Union Against Tuberculosis and Lung Disease, a global health advocate. And I can go on and on about her 15 years of experience in TB advocacy, but we really appreciate your time this morning.
Thank you.
All right, and we also have Dr. Immaculate Kathure with us in studio this morning. Currently, she's the acting head of Division of Tuberculosis and Lung Health at the State Department of Public Health and Professional Standards under the Ministry of Health. But she's a doctor by profession, skilled in epidemiology, medicine, prevention, monitoring, and evaluation of infectious diseases. And of course, she'll be telling us a bit more about what she knows, first of all, as a doctor, and also sitting at the helm of leadership in the department that addresses tuberculosis in our country. Asante, Daktari.
Thank you.
All right, so it's a few days after the World TB Day, so I know this is actually around the time that conversations around TB really pick momentum. But let's begin by how big a problem we are looking at, Daktari. Let me start with you. I just shared the global stats, which I believe have already transitioned because these are not like the latest as at today. But I want you to bring us closer home in Kenya. If you look at the situation in our country in terms of the TB burden, what are the numbers looking like?
Okay, so good morning. Kenya is ranked as one of those 30 high-burden countries for both TB and TB-HIV. And these countries, we look at them as countries that contribute over 80% of the global numbers of TB cases worldwide. Now, looking at the numbers for 2022, we saw Kenya notifying over 90,000 cases of TB in 1 year, of which 10,000 were actually children below the age of 15 years. And then we also had about 700 cases of drug-resistant TB also notified during the same period. And what I would say is, over the years, Kenya has seen a steady increase in the number of TB cases being notified. We did experience a few setbacks due to COVID, but we have seen a remarkable improvement and a tremendous increase between the years since 2021.
And I know you can tell us a bit more about that remarkable journey. Having been in the TB advocacy world for 15 years, Evelyn, we marked the World TB Day the other day, just a few days ago on Sunday. As somebody who has been at the heart of this particular epidemic, what would you say some unique or something that you'd term as, something that stands out for you with this year's celebration?
Yeah, thank you very much. You have rightly noted I've been TB advocacy for about 15 years, and I've seen tremendous improvement in TB response, not just in this country, but globally. And this is progress that we rarely talk about. We normally talk about, what we are not doing right, but today I want to talk about what have we done right. I'll start with the progress we have made in diagnosis. When I came into the TB world, we had very limited diagnostics for TB. We largely relied on microscopy. But now, over the 15 years, we have very many new technologies of diagnosis, which are quite fast, which are quite efficient, and which are quite accessible. I also want to talk about treatment. When I came to the scene, for example, in drug-resistant TB, we used to treat with about 24 months. We have now reduced that to about 9 months with no injectables. We used to have a treatment of about 6 months of injections. Today, we don't do injections. They just oral tablets. More closer home, let me talk about the human rights. Then there was very barbaric, I would call them, laws on people with tuberculosis. For example, there was a law that allowed patients to be jailed when they were not able to complete their treatment. That has since changed. We have also seen more engagement of new stakeholders, for example, persons who have been infected and affected with TB coming on board as key players in TB response. We have also seen a lot of increase in political commitment. For example, in Parliament, we have what we call the Parliamentary TB Caucus, whose one of their major roles is to do advocacy within Parliament. And also, at the global level, for 2 times, we have seen TB being discussed at the United Nations high-level meeting.
All right.
Which is quite significant step.
All right. I wanted us to start from that optimism, so that at least, the theme is yes, we can. So it's always good to show when you say yes, we can, what are we already doing that is encouraging us that we are taking steps towards eradicating TB by the year 2030. That's actually the target. But before we go into, the interventions, Dr. I'd like to take you back into now the basics. We may assume that people know what TB is, and let's move forward and have this conversation about policies and interventions, but maybe there could be somebody watching and they don't even know what are the symptoms, what is TB, how does it spread. So let me tap into the doctor in you and run us through the basics of what TB is all about.
So before I actually give the numbers, there's something that I would want Kenyans to know, and I really want us to appreciate and applaud the tremendous effort that the healthcare workers have really put in towards progressing TB control in this country, to an extent that Kenya is one of the very few sub-Saharan African countries that have actually achieved and surpassed the End TB strategy goals for 2020, with reduction in the incidence and the mortality for TB. So I think that's something, sometimes it's always good to give credit where it's due. Now back to your question, looking at the way TB is spread. TB is a bacterial infection that is spread from one person to the other through aerosol droplets, that's through the air. And that is when an infected person either coughs, sneezes, laughs, sings, talks. And unfortunately, just to dispel some of the myths, no, it's not spread by shaking hands, it's not spread by sharing cups and spoons. But however, the spread is faster when we are in enclosed spaces, in overcrowded spaces, without adequate ventilation. Now, TB can affect any part of the body, apart from the hair, the teeth, and the nails. It affects persons of all ages, all genders, all socioeconomic status. It does not matter whether one is rich, whether one is poor, whether one is young or old, anybody is at risk of contracting TB. Now, the good thing is that TB is treatable, TB is curable, and TB is preventable. So it's one of those diseases that we have an opportunity to actually make sure we can be able to control it in our community. Now, how does a person with TB present? And I'll give the general symptoms for somebody with what we'd call pulmonary TB, but they could also vary if the person has TB in any other part of the body. So TB generally would present with cough of prolonged duration. Usually we talk about 2 weeks or more. We also have weight loss. For children, we may have failure to gain weight or failure to thrive. We also have fever. That is fever. We also have night sweats. That drenching night sweats. You wake up in the night and you're drenching wet. We also have reduced playfulness in children, or what we call lethargy in adults, just generally feeling weak in the body. Now, what we always encourage the members of the public to do is, if you have any of these symptoms, approach any of our health facilities and ask to get a TB test. TB testing is free in all our public health facilities, and therefore we should be able to offer that invite to members of the public, not to hold back until it's too late, so that then they can be diagnosed early and then receive their treatment on time. Yeah.
Considering how it spreads, I think it's really necessary for us to really take personal responsibility,
Yes.
to be able to avert further spread of this particular disease that actually, is becoming quite a problem. But then, Evelyn, just to add on to that, if we look at the types, talk to us about the drug-resistant TB, for people to understand the different types of TB and probably how disastrous they can be.
Okay. Drug-resistant TB, in layman's language, is TB that has resisted the first-line treatment. That means it needs to be treated with a stronger regimen of antibiotics. And, of course, it takes longer to treat. And it's also very expensive, especially on the government, because normally the treatment of drug-resistant TB is taken care of by the government. And there's so many causes of drug resistance. First is not adhering to the treatment the first time that you're given the treatment. You can also, if you sit next to somebody who is coughing with drug-resistant TB, then you're going to get that strain of drug-resistant TB. Okay? Yes, so that's basically what's...
Okay. And I know there's a lot that has been done in terms of interventions. You talked to us earlier about nowadays the dreaded injections that used to go for 6 months are no longer there. And probably, Daktari, just to rope you in, what other interventions do you think the government has done? Some of the measures that you described that the government has been able to do to really manage this particular crisis?
Okay. So one of the things that we've grappled with is being able to find the missed cases of TB. Because of stigma within the community, a lot of people with TB are not quick to present themselves to a health facility and get diagnosed. So a lot of intensified efforts have been undertaken by the government through the Ministry of Health to actually go to the community level to be able to undertake what we call screening and active case finding. That means going for community outreaches, screening within health facilities so that irrespective of what condition the patient is presenting with, then they get to go through a symptom screen for TB. We've also tried our best to increase awareness among members of the community, both through the media, through community barazas, through health education. We've also done a lot to strengthen the ability of the health system to diagnose TB. We've undertaken very robust training of our healthcare workers to make sure that when patients present, then they're better placed to diagnose them. We've also worked a lot to adopt and scale up innovative diagnostic solutions. Evelyn has well mentioned that we've moved a long way from microscopy. When microscopy was the only way to diagnose TB, we used to take 3 samples and a patient would take 2 to 3 days to actually come back to the facility every day to get diagnosed. Now we have tests that can actually diagnose TB in well under 1 hour within our public health facilities. And then we also have others that can actually be used right at the community level. We have seen the government go ahead and accelerate the adoption of digital x-rays with artificial intelligence so that even right within the community level, we can actually screen and identify TB and immediately start our patients on treatment. The other thing we've done as our ministry is to also scale up the adoption of high-quality treatment regimens. So one of the things the ministry does is the treatment regimens that we use are the ones that are adopted and the ones that are WHO recommended treatment regimens. So that at the end of the day, we have regimens that are of high quality. We also have medicines that are suitable for the various age populations. So for example, just to make sure that the children who come down with TB are able to receive quality treatment, we have what we call child-friendly TB medicines. They're strawberry flavored. They're able to dissolve in water. So it means the caregiver is better placed to be able to give that medicine to the child. Now, the treatment regimens have evolved over time. As Evelyn has mentioned, we came from the days where we used to give months of injections for drug-resistant TB. We've seen...
And a prolonged waiting time as well?
Before treatment, yes. So now, if you're diagnosed today, you start your treatment today. And the treatment is free in our public facilities. And then also making sure that the regimens in use are friendly. So we've seen transition from injectables to injection-free treatments for drug-resistant TB. We've moved from 20, 21 months, we moved to 18 months. Now we are on our way for drug-resistant TB to move to a 6-month treatment regimen. For children, we've now recently adopted a 4-month treatment regimen in place of 6 months for children who don't have severe TB.
All right.
Yes.
And I'm wondering, Evelyn, from your perspective, why do you think TB is still a public health challenge despite these very good efforts that the government has put in place? You thrive in the local communities and the advocacy and the awareness. You see what the realities on the ground look like. Why do you think we still have this as a very big problem? What is the missing link?
Yeah, first of all, when you're talking about it being a public health menace, what do you mean? And I want to maybe substantiate that. You know, when a disease is killing about 22,000 people in 1 year, that's a serious problem. If you look at the numbers that we lost during COVID, for 2 years, Kenya, we lost about 7,000 lives. Now imagine, per year, we are losing about 22,000 lives to tuberculosis. That's serious. And what also makes it a challenge is because it's airborne, it's transmittable, it's infectious. If it was a disease that once I have it, I just struggle with it on my own, it would not be a big problem. But now the fact that one person would infect others, then it becomes again a big problem. But you asked, where is the missing link? Yeah. The first problem from where I stand is low levels of awareness. Because when you don't know that there's such a disease, or when you don't know the signs and symptoms, you don't know where to seek treatment, you don't know the fact that you need to adhere to treatment for 6 months. You know, our common practice as Kenyans is once we get sick, the first thing we do is go over the counter, or we self-medicate. We have the habit of boiling ginger, lemon, garlic.
Wait it out. Itaisha too,
you know.
Yeah.
And also sharing drugs. So I go to hospital, I use for maybe 3 days, I feel better, then I leave it and I give the next person who has the same symptoms. So lack of awareness is such a big problem. And that's why, like my Daktari has said, we are putting a lot of investment in creating awareness. And I want to say that we need to sustain this campaign so that we are not just talking about TB in the month of March. It's supposed to be a year-long campaign like we did with COVID. The other problem that we have is normally among men. I don't know whether Dr. has mentioned that men are more affected with TB than women. And one of the biggest problems is that men shy off from seeking medical care. And though there is no research that has been done to say why are they more vulnerable. But when you look at their way of lives, the places they go, maybe to the drinking dens, there are places that expose them to TB. The other challenge is that we have left TB to be we have left the Ministry of Health to wholly take TB, to really address TB. But TB is a problem of every sector because TB will be it's spread in matatus, it's spread in schools, it's spread in the sports field. The Ministry of Health can only manage maybe what comes to the hospitals, but what is outside the hospital has to be taken care of by those sectors that are working within those sectors. So we are looking towards a place where every sector will look at what is it within my core mandate I can do to address TB. I'll pick, for example, schools. If the Ministry of Education would come up with policies of prevention of TB within the school setups, taking care of the patients who are within the school setups, having policies, for example, for screening for TB at least once a year, like they do deworming. We can take care of that TB that is within the schools. If we look at the Ministry of Transport, the TB that gets transmitted in the matatus, and the Ministry of Transport takes up that responsibility, creating awareness within the matatus, maybe training the matatu crews on window opening, and even talking about TB within that sector, then we would ease the burden of TB from the Ministry of Health and spread it across all other sectors. that is what is really lacking.
It's sort of like a change of strategy. So everyone is needed on board, yeah?
Yeah.
It doesn't matter where you are, because that place, that small corner of the world, that is the place that you can actually play a very pivotal role in preventing the spread of tuberculosis. Yes. Dr. Hari, this year's global theme for the World TB Day was centered around, yes, we can end TB. But in Kenya, we kind of customized it, embracing primary health care to end TB. That's the theme that the Ministry of Health was running by. I'm curious to know why this was significant, looking at primary health care as a key pillar in really eradicating this epidemic by the year 2030. That's the goal that we have. Why is this significant?
Okay. So the essence of why we adopted embracing primary health care to end TB is pivoted on several factors. One, the Ministry of Health, the government of Kenya currently, is very keen to enhance primary health care and promote universal health coverage. This is because if we look at the patient pathway, most of our patients seek services first and foremost at primary health care levels. And that is where we have the highest opportunity to find the missed cases of TB. So working through our primary health care structures, we are better placed to be able to identify TB early, make sure we can diagnose it and successfully treat it. Secondly, it is through that primary health care approach that we are also able to take TB beyond the primary health care facilities to the communities where actually the patients are. Therefore, working through our primary health care structures, using the community health promoters program to be able to reach the members of the community, to be able to identify those with symptoms amongst us that have not yet reached the facility, then being able to refer them for care and treatment. And then also making sure that at the end of the day, those that have maybe dropped off their treatment are able to be found again through the same community health and also primary health care mechanisms. And for those that have already been started on treatment, being able to use the same channels to support them through their treatment so that then they're able to successfully complete their treatment. The other benefit of using the primary health care approach is that at the end of the day, we have adequate human resource at primary health care levels that can actually be able to screen and identify TB. They have been trained, and as opposed to the number of people that go to a tertiary referral hospitals, we reserve those ones for the complicated cases or those cases that are very severe. But at least being able to use the grassroots to be able to identify TB early is going to be our game changer when it comes to curbing the spread of TB.
Still a very big burden. I was quite concerned when you mentioned over 20,000 people dying annually because of TB. Something needs to be done, really. And I would like us to look at this holistically, even looking at the socioeconomic drivers of TB. But before we get to that, Evelyn, just run me through awareness vis-a-vis advocacy. Yours is really pegged on advocacy. Tell me the difference and the interlink between these two, pathways of intervention and management of tuberculosis.
Okay. Yeah, let me bring the difference between advocacy and creating awareness. Creating awareness is a strategy in advocacy that you need first to create awareness so that you have support for whatever issue that you want to do advocacy around. So
the goodwill, the foundation of
exactly,
goodwill, yeah?
Yes. So you need awareness for you to succeed in advocacy. Advocacy is agitating for change, especially at policy level. Okay, I will give an example of advocacy. I mentioned to you that when I started working on TB, we had issues of patients being jailed, right? When they failed to adhere to their treatment. That is not an issue these days. How did we get there? We'd had to do a lot of advocacy by saying a TB patient is not a criminal. Prisons are for criminals or people who have gone against the laws. But this person is only that he has been unable to adhere to treatment, and he has reasons for that. Remember that when he came to hospital in the first place, he wanted to get medication. So he can't just stop taking medication with no reasons. So we are saying, let's first address the reasons that make this person not adhere to treatment. So we had to do a lot of advocacy, sit with the different stakeholders and make them get our point of reasoning. And that's when now the law, a directive was given that TB patients who are not able to adhere their treatment will not be put in prison, but they will be put in a medical facility where they can be given that treatment in isolation, in a place where they're being taken care of, but not in prison. So that needed a lot of advocacy. Another example, again, we had been using microscopy from those days, and we did not have, for example, diagnosis for drug-resistant TB in this country. We used to ship the samples to countries like South Africa or Australia, and it would take up to 6 or 9 months before the results are brought back. By then, most patients died waiting for their results to be back. Again, we had to do a lot of advocacy for investment in research and development for better diagnostics so that we reduce this waiting period. And that's how far we have come with now a diagnostic that you can be tested and receive the results then, from waiting for 9 months to just a few hours. That needed a lot of agitation from not just country-level advocates, but even global level. Yeah, so that's how advocacy came in, agitating for change.
What birthed the Parliamentary TB Caucus, and what would you describe as its impact in the work that you do?
Yeah, the Parliamentary TB Caucus was birthed in 2014, and that was after the review of the end of Millennium Development Goals. The MDGs were ending in 2015. Just before then, there was a review of how countries had performed in their different sectors, TB being one of them. And they realized that most countries did not achieve the MDG, the Millennium Development Goals. And they did an analysis. What made us not meet the targets? And there were quite a number of reasons, but I'll talk about two. One was low political commitment, and the second one was low levels of funding towards TB. And so stakeholders had to come with strategies to increase these two, funding and political commitment. For political commitment, two things were done. Coming up with a global movement of parliamentarians. So the caucus is not just in Kenya, it's a global movement. It was actually birthed by a member of parliament from the UK. So every country is supposed to have a national parliamentary TB caucus. Number two, we had to work with the heads of states. We had to also ensure that the heads of states come in for political commitment. Yeah. And that's how we got an opportunity to have TB as an agenda at the United General Assembly. And like I mentioned, we have had two opportunities. That is 2018 and 2023. So what has been the impact of this? Their role is supposed to do with advocacy for resource mobilization at the country level, and also from the donor governments. So they will talk about, right now we're in the budgeting process, the Parliamentary TB Caucus is supposed to sit with the budgeting committee, and they make a case for TB to have increased allocation. So they will do it at our country level, and even when we are looking for funds from those global sources, the caucus is also supposed to be there. For example, when you're talking about the global fund replenishment, they will go and talk to the donor governments to put a case for tuberculosis. And we have seen a lot of tremendous improvement, increase even in funding, not just from our country, but even at global level because of their intervention. And like she mentioned, Kenya is one of the few countries that have met the NTB target. And out of the 10 countries that have achieved the target, 7 of them have a parliamentary TB caucus. That tells you there's a very big relationship between political commitment and the country making progress in TB response.
Yeah. There has to be the goodwill, the political goodwill. So Dr. when she talks about funding, how are we looking like in terms of how they say put your money where your
heart is?
I don't want to say the other one. So how are we doing in terms of how much we are putting as a budget for TB? Okay. And I want you also to compare what we are doing locally, like our internal mobilization of resources, vis-a-vis what is coming from the donors from outside.
Okay.
Yeah.
So I'll say this. One of the things that we have seen as a measure of strong political commitment is a progressive increase in the investments towards TB in Kenya. And we've seen the amount of resources go up over the years to an extent that Kenya is one of those few countries where over 70% of our investments toward treatment of drug-sensitive TB actually from government, as opposed to when we started, when almost all of that was being funded by the donors. And towards that, Kenya has been one of the countries that was lauded during the last UNHLM, United Nations High-Level Meeting of 2023, as the global leaders were launching the Coalition of Leaders Against TB. His Excellency, the President of Kenya, was one of those leaders that was lauded for the commendable effort in showing political commitment towards ending TB. So I would say Kenya has done a lot. Now, the other thing that we've also seen is looking at the funding landscape. Out of the resources that we need to be able to manage TB over the years, we've seen a progressive investment in the proportion that government is putting in. As I have mentioned, we have much more going in from government for treatment. We are also seeing increased investments in our diagnostics. And when we compare with what other countries are doing, we have other countries where almost all their TB control resources are actually from donors. However, for Kenya, we are seeing a blend between the donors and the government. The other thing that we've seen, I would want to say, some of the people, the donors that have also come out strongly to support us, apart from the government, are donors such as the Global Fund. We've seen donors such as the US government through either their PEPFAR resources or through the USAID grants. We've also seen other donors such as UNITAID. We've seen all these donors come in to be able to support the TB response within Kenya.
Right.
Yes.
Evelyn, what would be the impact if you look at the concern that has been, even in what she's saying, other countries fully relying on donor funding for TB interventions? What would be the impact? Over-reliance on donors vis-a-vis really mobilizing internally your resources to manage the crisis from within. What would be the difference in terms of impact?
Yeah, I would say there's a danger in a country over-relying on donors for their health interventions.
Yeah.
Because, of course, donors have their priorities too. And in the past few years, donors have been winning out countries out of over-reliance on their funding, and they're calling on countries to do what you're calling domestic resource mobilization, more relying on their own resources. And I will give two perspectives into that. To the donors, I would say, we know, yeah, of course, you have your own country priorities, but we are in the final, I would call it the final leg towards ending TB, by 2030. And so much as they would want maybe to withdraw now, I would say it's not the right time to withdraw, because we need up to the last coin right now to finish the final leg towards 2030. So, yeah, I would ask them to just hold on.
We're in the home stretch.
We're in the home stretch. And to the country, I will applaud the government for the much they have done in TB. However, I feel we can still do more. We can still do more investment to TB, and I would particularly want to task the county governments. When we look at the budget allocations from the county governments, we realize that they don't do much allocation to tuberculosis, leaving it as a burden to the national TB program or the national resources. But now that we're in the budgeting process, if we could ensure that county governments allocate TB to the county budgets, okay, even as the national government does their increase, we also urge the counties to do their bit, and also the private sector. I love borrowing from COVID. We beat COVID because even the private sector came in large numbers to invest in COVID. Every time we had company X has put so many dollars, why are we not seeing this in TB? So I would also urge the private sector to look at what amount are they willing to invest in tuberculosis. Let us not just leave it to the government and donors.
All right. I want us to cross over and look at the socio-economic drivers of tuberculosis. Dr. I'll come to you. But Evelyn, just to paint a picture for us, they say poverty is an enemy of progress. Let's put this in context. In the fight against tuberculosis, in this efforts to eradicate tuberculosis, how is poverty dragging us or thwarting the efforts of achieving success in this, spectrum?
Yeah, I say TB is a development issue. There is a development issue in that most of the drivers have to do with development or have to do with poverty. For example, if you look at congestion, why is there congestion? Because we don't have adequate housing, or we are living in congested houses that don't have ventilation, then they're not well built. Talk about malnutrition. Malnutrition is a driver to tuberculosis. Malnutrition will come because we don't have enough food. Okay. When we look at low levels of awareness, some of it is because we have low levels of education. If you look at countries that are developed, they have adequate education, so they are able to access information around tuberculosis. So, not just tuberculosis, around health. So for us to eradicate tuberculosis, we also have to ensure that we are developing as a country. We have proper housing. We have access to food. We have food security. We have proper transport system. We have proper levels of education. So we have to develop as a country for us to eradicate transmittable diseases like tuberculosis.
Dr. I'd like you to also weigh on that specific issue, looking at the socio-economic drivers of tuberculosis and in the interventions that the government currently has. How are you, marrying these two aspects? Because I understand that TB is a medical problem, but we cannot address TB without... It's a social problem. Yeah, it's a social problem and an economic problem as well. Yes. So how are you staying alive to these realities in terms of the interventions by the government?
Okay. So one of the things that I would want to affirm, and also is a driver to the TB disease, is other social habits such as alcoholism. That is a big burden to us in Kenya today. What happens is, for example, when patients imbibe too much alcohol, they're more likely to be in crowded spaces, they're more likely not to seek treatment, and they're more likely not to adhere to their treatment, further fueling the spread of TB and also drug-resistant TB. Back to your question as to what we've done as a government or as a country. One of the things that we're doing is, as a program, we launched what we call the multi-sectoral accountability framework. What that framework does, it provides the guidelines for engagement with all sectors. Working closely, for example, with the Ministry of Education, we are currently developing guidelines for TB screening within institutions of learning. We have had collaborations in looking at the school curricula that is being used to make sure that the messaging on TB is actually right. We are working with children, creating advocacy among children and using them as agents of change within the communities where they're going back to. And a good example is the music festivals last year. The theme was actually around tuberculosis, just to make sure that the children are also doing their part to help in the fight against TB. Now, looking at the housing sector, for example, we're also looking at collaborations in advocating for policies in housing design that encourage adequate ventilation. We are working with Federation of Kenya Employers, saying that we need to create safe workplaces whereby persons are not contracting TB because of the environment they're working in, but even when they contract TB at work, then they are supported to go through treatment without the risk of losing their jobs. So we are also collaborating, for example, with the private health providers to make sure that when they offer care to patients that may access services in the private sector, then they are offering quality care comparable to what is being offered in the public sector, so that across the board we are working with everybody, not just to mobilize resources, but to also make sure that we are managing the patients. Now, back to the issue of nutrition, for example, one of the things that we are working with Interior Coordination Department is to make sure that, for example, when they are issuing food rations within the community, we are creating awareness to ensure that they prioritize, for example, persons with TB. Because we know malnutrition is a risk factor for mortality among our TB patients. So we are making sure that nobody is actually being left behind. So also when we look at beyond that, we're looking at climate, and people will ask, so what does climate change have to do with TB? We are there also. We are working with the climate, the environment team, because we know when we are able to take care of our environment, then we will curb issues such as malnutrition, which are actually going to affect the way our body is able to fight off diseases, therefore reducing the incidence of TB. When we are able to tackle climate change, we will reduce things like flooding and drought, because then in such circumstances, either patients will not be able to access services, or services will not be brought to the people, for example, when there is flooding. But in instances of drought, for example, we'll find that particular instance will fuel the spread of TB because of malnutrition. So as Evelyn said, TB is not a burden for the Ministry of Health. TB is a collective responsibility of the people of Kenya and the world at large, because whatever it is that we are doing every day has a chance to make a difference, to stop the spread of TB, or to encourage a patient to seek care, or to encourage a patient to complete their treatment.
As we talk about treatment, Evelyn, just, back then people used to die because they cannot access treatment, because probably the cost implications and all that. As we create this awareness this particular morning for somebody who could be watching and they're wondering, how have we progressed with regards to the burden of cost in terms of management of TB and treatment of TB? What would be your words to them?
Yeah, I would say treatment of TB it comes at a cost, especially to the person. Much as the government has taken a huge responsibility and provides the treatment for TB for free, but the patient has to use money to go to the hospital. They have to go quite frequently to get the treatment. They have to get proper feeding, which comes at a cost. Even the diagnosis is not taken care of by the government. You have to pay for it. So there's still a cost to tuberculosis, and it's not a small cost. But we have seen a lot of progress, especially the highest cost was coming with the drug-resistant TB, which has greatly reduced because, without the daily injections, that means you don't have to go to hospital every day like they used to go, especially for the injections. However, the WHO has put a target of having zero catastrophic costs on the TB patients. And so governments are really working to ensure that TB patients do not incur any costs. And that will come by way of ensuring that they're giving social support. For example, the drug-resistant TB patients are given an allowance of 6,000 Kenyan shillings per month. This is to facilitate their travel, and it's in a way to ensure that they do not incur any cost. We're also working with the UHC to ensure that TB is included in the UHC package, again, so that we reduce the cost that is incurred by the TB patients. And so we are looking at the UHC package to ensure that TB is in that package. Yeah.
The 6,000 allowance, has that already been operationalized in our country? It's working?
That has been there for almost 10 years now.
All right. At least that has taken us some steps ahead, yeah?
Yes, because and also maybe also to add that also MDR TB patients are put on NHIF. As soon as you're diagnosed with drug-resistant TB, you're put on NHIF. And it runs for 2 years. That means it takes care of any admission or any costs that may come when you're on drug-resistant TB.
All right. Dr. Would you like to add on that?
Yes. Actually, I think Evelyn has very well articulated it, that at the end of the day, there are a lot of efforts that are going towards cushioning our patients from what we call catastrophic costs from TB, which actually the burden is borne much more by the patients with drug-resistant TB. Now, the other thing that we're also doing apart from that is offering what we call community dots, which is supporting patients within their communities. So, for example, if patients need drug refills, and this is a stable patient, instead of the patient coming to the facility, we are using our community health workers, our community health promoters to be able to give them what we call drug refills, and then they only come back when they need to be reviewed. And as she mentioned, we're also working very closely with the team that's developing the benefits package for social health insurance to make sure that the little costs that patients were paying for diagnostics such as x-rays, then now those will no longer be there, so that TB diagnosis and treatment will be absolutely free in all our facilities. The other thing that we're also doing is for community screening. Sometimes you find that patients may be screened, for example, during an outreach, and they are not able to access a health facility immediately because going to the facility was not one of those things we're prepared to do. So we offer what we call specimen referral. So we are able to mobilize specimens through the community health promoters, the community health workers. We take them to the facilities. We are also able to mobilize specimens from peripheral facilities to the central testing lab, and also be able to take the results back so that then the patient only goes to the facility now with a complete diagnosis to be able to start their treatment. Strengthening our sample referral network has actually helped to cushion the patients against the movement costs. The other thing that we are doing that will also be coming in the next few days is, as we are deploying the use of ultra-portable digital x-rays, that's one of the costs that if you look at the number of equipment in this country, they're very few. And patients had to move, for example, to sub-county level 4, level 5, or level 6 health facilities to seek a basic service such as an X-ray for TB diagnosis. So as we are deploying these instruments and equipment at primary healthcare facilities, it means now the patient no longer has to move. That diagnosis is actually coming as close to the people as possible, including to community level, and it's now going to be offered for free. So just making sure that we're cushioning them, not just against the costs incurred within the health system, but also the other costs that are incurred by the patients themselves.
All right. The optimism has been sustained all through the program, I guess, and we can say indeed, yes, we can, end TB.
Yes.
But as we wind up, just to give you a chance to give us your final thoughts, the commitments that were made by the heads of state in 2023, there was a similar high-level meeting discussing TB in 2018. Have we moved beyond commitments to real action points for us to really realize this dream of ending TB by 2030? What will it take for us to really make this dream a reality? I'll start with you, Evelyn, then I'll end with you, Daktari.
Yeah, moving from commitment to action requires leadership, requires political leadership. And my ask is to the leadership of this country to look at TB more seriously. A disease that is claiming 22,000 lives per year is a disease, it's a huge burden to the economy of the country. Therefore, we are looking forward to the political leadership to invest more, to invest adequately towards ending TB. And because we have seen, Kenya has demonstrated that we are making steps. Therefore, with just a little investment, we can meet the target of ending TB by 2030. It is possible.
Daktari?
Now, for me, my call is, apart from the call for increased investment, because we still have a long way to go in terms of the resource requirements that we have, my plea is to Kenyans, so that at the end of the day, wherever we are, Kenyans of all walks, all persons, despite of our socioeconomic status or where we are at in life, we make sure that if we have any symptoms of TB or symptoms that may be suggestive of TB, let us access diagnosis within our health facilities. Let us start our treatment. Let us complete our treatment. In addition, one of the things we're also offering is preventive therapy. So for those that are contacts of confirmed TB cases, the Ministry of Health is actually offering preventive treatment to make sure that their contacts do not develop TB. I urge all Kenyans, when this is offered, let us take it up, because then if we can curb the spread, then we will be very well on our way to eliminating tuberculosis.
All right, thank you so much. Evelyn, there's going to be a 7th global
management.
Yeah, on TB in October.
A 7th?
A 7th global sit-down on just to discuss TB in October. I saw something like that.
Conference.
Oh, the Union Conference. Yes.
Yeah?
Yeah, the Union Conference takes place every year, every once a year in November. It's a platform that we bring researchers and all stakeholders that are working on lung health to discuss progress and also come up with new strategies on how to address lung health and TB. And so, yeah, it's going to be there in Bali.
All right. I hope that by that time we'll have some more things to celebrate in terms of the milestones we have achieved as a country. But I've been engaging this morning Dr. Immaculate Kathure, the acting head of Division of Tuberculosis and Lung Health. It's at the State Department of Public Health and Professional Standards under the Ministry of Health. This morning also having this conversation with Evelyn Kibuchi, Chief National Coordinator, Stop TB Partnership Kenya, also a board member of the International Union Against Tuberculosis and Lung Disease. Thank you, ladies, for creating time this morning. And thank you also for watching Daybreak. We really appreciate your company. That's how we wrap it up. Have a lovely day and enjoy the rest of your viewing.